Hey everybody, my name is Peter Nesper. I'm a medical student at Rosalind Franklin University, and I do research in Dr. Amani Fauzi's lab at Northwestern University in Chicago. So today I'll talk to you about modified geometric perfusion deficit analysis for detecting clinically referable eyes with diabetic retinopathy. And we did this research in Dr. Fauzi's lab at Northwestern, and I also had a research committee at Rosalind Franklin. So I'd like to thank Dr. Laduca, Dr. Ebihara, and Dr. Cam for all their help along the way. So we hypothesized that geometric perfusion deficits, or GPD, will distinguish clinically referable eyes in a cohort of patients with diabetes with a high sensitivity and specificity. We also thought that GPD will perform better than vessel density. So we're going to talk about why we might care about this hypothesis, what do we mean by clinically referable eyes, and also get into a little bit about the Chen study who introduced GPD, and then talk about the current study. So as you all know, diabetic retinopathy is a very widespread disease, it's very prevalent. There's millions and millions of people worldwide, and these numbers are unfortunately just continuing to go up. So part of the purpose of this study was to try to figure out a way, or a first step, and try to figure out a way to use OCTA as a screening tool for diabetes. And the burden of screening is very high for these patients. The recommendations in the US are for type 1 to be screened within the first 5 years of being diagnosed with diabetes. And for type 2, they're supposed to get screened at the diagnosis. So regardless of whether you're type 1 or type 2, following this first screening, they're supposed to get yearly follow-up screening visits from then on out. And this is a lot of money and a lot of time, and there are barriers to care, such as currently, with the COVID-19 pandemic, patients aren't going in, they're staying home and not getting the screening they're supposed to. And even the Royal College of Ophthalmologists recommended postponing routine DR screening in these patients. And another thing we think about is racial and ethnic minority populations who are actually more likely to have poorer glycemic control and less likely to be screened for diabetic retinopathy than their white counterparts. So this is kind of a first step towards figuring out a way that we can use this camera as a way of screening for these patients who maybe can't get to a doctor or don't have the resources to get to a doctor until they really need it. So clinically referable is just based off of color fundus photographs. It's the standard ETDRS rundown of your severity of diseases. And anything that's moderate or worse, we're calling clinically referable. So these are patients that should be seen by a retinal specialist for follow-up of care. And this includes patients with DME as well. So we use OCTA, we use the OptiView. It's quick, it's non-invasive, gives us great pictures of the retinal vascular. So geometric perfusion deficits, this is the Chen study. And so they define GPD as anything that's greater than 30 microns from the nearest blood vessel is going to be considered a perfusion deficit. So this is based off of oxygen diffusion studies in the retina, which show that anything that's greater than 30 microns is going to be more likely to be in a hypoxic state, more starved for oxygen. So in this figure, they show GPD in the center, and they compare it to two other commonly used and very useful variables, but this is just a few examples where in specific situations, GPD might perform a little bit better. So in this example, there's a small discontinuation of the vessel here, and you can see that it's going from this yellow and blue to this orange, so it's a little bit more severe, whereas GPD sees this and it's basically close enough to a blood vessel where there's still enough room for diffusion of oxygen, so it's probably not in a hypoxic state, it's probably not a more severe or more sick eye in this situation, and GPD doesn't count it as more severe. In this example, you can imagine that if a patient comes in and they have some edema that's pushing the blood vessels to the side, you have this area here, which in vessel density, you may not pick it up. It might not be shown as more severe. Whereas GPD sees this large area and they're going to call it ischemia, so they pick it up as a more severe scan. So in our study, we did a retrospective analysis, and we took patients that were imaged on the OptiView between 2015 and 2020. We did a strict quality check, Q-score of greater than 7, limited motion artifact and shadowing artifacts. We did our chart check or clinical imaging to obtain the DR status. So in about 2/3 of patients, we had these Optos or color fundus photographs, and we did the diagnosis ourselves. But for the last 1/3 of patients, we just did what the clinician wrote on the chart that day. Exclusion criteria is anyone with high myopia or any other retinal disease, including glaucoma suspects, AMD, even if they had drusen, we did not include these patients. And so we wanted to compare it to vessel density, and we just took this right off the camera, right off the OptiView itself. We did paraphobia, we did it in the full thickness, we did the superficial, and as well as the deep. Then we took the full thickness scan, put it in ImageJ, and did a manual tracing of the FAZ, and we got a FAZ in millimeters squared. And then, so how did we get GPD? So we used ImageJ, we made a macro, and the first step of that is to binarize the image, and we used the Huang-2 thresholding, global threshold, and as you can see, these capillaries are pretty thick. So they're pretty fat capillaries, and I understand that this is a problem with OCTA itself, and these capillaries are thicker than they are in real life, but this is made even worse by some of our thresholding methods. So what we did was skeletonize the capillaries, and then we kept the large vessels in there because we didn't want to skeletonize these and make new GPDs because there's a large area around the vessels. So we basically took the large vessels and overlaid it with the skeletonized capillaries and put this into our algorithm, and the output is shown here. So white vessels, and then there's this black 30 micron space around the vessels, and everything outside of that is in red, and that's going to be your GPD. And it's the same thing as FAZ, it's just a millimeter squared, and we did this with and without the FAZ included. So here's a breakdown of our patients. We had 151 patients. We took one eye from each patient, whatever had higher quality scan, and we had 81 non-referable eyes as well as 70 referable eyes based on our color fundus photographs. And some of the results here, so our main results are going to be the ROC curves and the area under the curve, so I didn't want to bog you guys down with too many tables and numbers, but I just wanted to show you the magnitude of what we're getting for these GPD parameters. So this is with the FAZ included, and you can see that we have an increasing number of GPD as severity goes up, which we expected, and then we get to this bottom one, which is basically the DME group for clinically significant macular edema. And this number is a little bit lower than some of the more severe eyes. Now, we think this is just because we know that we included patients regardless of their DR status, so whether they have moderate NPDR versus PDR. If they had clinically significant macular edema, they got put in this group, and that's the group that they're in. So here's a more severe case. Here's a less severe case. You can see there's less red there. We can compare it to PDR, which usually is a lot more red and a lot more GPD. And then here's the main results of the study, the main outcomes. And so this is going to be the ROC curves on the left here. It's a little bit busy, so I'll just point you over towards the table. And the best performer here was geometric perfusion deficits of the deep when the foveolae vascular zone was not included. And this is going to be the green line. The worst performer, which we kind of expected, is FAZ, and that's going to be this red line here. So importantly, when we look at the comparison between vessel density and GPD, and these are all circled here as all the full, as you can see, the GPD performed better than vessel density. And this is the same as in the DCP. The SCP is a little bit different, so there's one that's better, one that's worse, but overall the top performer was still GPD in this case. So to conclude, the geometric perfusion deficits in the DCP with the FAZ excluded performed the best in distinguishing eyes. They should be referred to a retinal specialist. And the GPD performed better, the vessel density in 5 of the 6 comparisons. GPD on OCTA should be considered, we think, as a potential screening tool for patients with diabetes. And you can see on the bottom here is a little bit of a rundown of how the worsening severity we have GPD getting more and more. So limitations, we did have an unequal distribution of eyes in each group, and we also included treated eyes in this study. So we want to do a follow-up study with a larger number of patients, hopefully with multi-centered, we can get rid of some of these issues. We also don't have a fully automated algorithm yet. There's one step that is manual, but my second grader on this study, Janice Ong, is currently working on that as we speak. Thank you.